Dr. Paul Hruz is an associate professor at Washington University. He is a graduate of the Medical Scientist University in St. Louis. He's graduated from the Medical Scientist Training Program at the Medical College of Wisconsin, completed residency training in pediatrics at the University of Washington in Seattle, with a fellowship in pediatric endocrinology at Washington University in St. Louis. As faculty at Washington University, has served as Fellowship Program Director and Chief of the Division of Pediatric Endocrinology and Diabetes. He is a member of the university's Disorders of Sexual Development Multidisciplinary Care Program. Dr. Hruz has authored over 60 peer-reviewed manuscripts, scientific reviews, and book chapters. And it's been a great honor for us to have him travel here from St. Louis to share with us his expertise in this area of a lot of controversy and focus of discussion on a national level. So, thank you.
I want to thank all of you for being here this evening at this late hour. Since this is a CME offering here, the disclosure that I have no financial disclosures related to what I'm going to talk about. And for the purposes of insanity, I'm not representing Washington University or St. Louis Children's Hospital. Let's just take a moment in prayer and give thanks to our gracious and loving Father and acknowledge His presence here among us this evening. We ask for an outpouring of His Holy Spirit to open our hearts and minds to hear what He wants to give to us so that we will receive that gift to be better stewards in the work that we are doing to alleviate suffering in all areas of our practice. We offer this all in thanksgiving through our Lord Jesus Christ. Amen. All right. So this is a very, very contentious topic. It shouldn't be, perhaps, but one of the reasons why I've never encountered anything in my years of practice that has generated more of a visceral response, more emotion, both from people that are advocating for the treatment paradigm that I'm going to present and those that oppose it. And perhaps the reason for that is because what we're talking about is identity. This is something that is very core to our very being, of how we perceive ourselves as individuals within ourselves and our relation to other people. It's something that we all guard very, very carefully. So perhaps it isn't a surprise that when somebody challenges somebody's identity, it's going to generate a response. What's often missed in this conversation, because I'm going to spend most of my time talking about science. I'm going to bring in a little bit of ethics and it's out of necessity talk a little bit about the kind of the philosophical underpinnings of what we're going to be talking about. But it's very easy as we enter into this discussion to lose sight of the fact that we're talking about real human beings. Explicitly is that these children are asking for help. They're suffering. They have much that they're just asking us as physicians and healthcare workers to help them in the struggles that they're having. And it's well known in this area of individuals that have gender discordance that there's an alarmingly high rate of depression and suicide and substance abuse. In fact, children with gender dysphoria, about 50% of them will contemplate suicide. And unfortunately, about a third of them will act upon those thoughts. As they get older, they're known to have problems with poverty, homelessness, HIV infection. All of this is something that should be very alarming to us. And our response as Christian healthcare workers should not be to run away. Much of the things that have happened in these children's lives have taken away a lot of their freedom. They're not freely choosing to have this distress, but they are coming to us for help. So what I want to spend, but before I get into, this is a CME talk, so I think the program actually summarizes the goals and objectives a little bit more succinctly than in that slide there. Now, as I said, I'm going to be talking about science, but I do think we need to say a few words about the underpinnings of what we're talking about here. And again, in this audience here, I think that you will recognize very readily what I'm about to say. But we are talking about science in the culture amongst the situation of a growing cultural divide. And this divide presents two diametrically opposed ideas of what it means to be a human person. I think everyone in this room would accept that we see the human being as being created in the image and likeness of God, as male and female. That we have built into our bodies a complementarity with a sexuality that only makes sense in relation to the other. And there's so much more that I could say about that. But it tells us something about our God. Trinitarian understanding of God. That we, God is love. And we learn about sexuality in the context of love. That it's directed toward others, not ourselves. The other side of the cultural divide presents man, not created in God's image, but created in his own image. Not as male or female, but as anything that the mind can conceive. As opposed to our understanding of the unity of body, mind, and soul, there's a very active and open assertion that the mind is distinct from the body. And that when there's a discrepancy, the mind rules over the body. The body is secondary and sometimes irrelevant. We need to acknowledge that, because when I present the scientific evidence for what is going on within our professions, many times we scratch our head and say, how could this happen? I think that there's much in this first slide here that actually answers that question. Now, you would think that, amongst physicians, we wouldn't need to define what sex is, right? I mean, we all know what sex is. But I think it's really important that we have our terminology straight and we know what we're talking about, because I want to empower each of you to be able to engage in this dialogue. One of the things that is happening very rapidly is a confusion. First, the definition of a separate entity called gender, in contrast to sex, but then mistaking, or at least in speaking about this, using gender where we mean sex. Okay, how many times I do experiments and I go to meetings and we're talking about people have posters about the gender of their experimental animals, and I always like to ask them, how do they know what their gender is, right? So sex is something that's very, very precise, and we know this. We've known this, for as long as we've been human beings. We define sex in relation to the process of reproduction, and we would say procreation. That the male and female roles are very well defined, and that doesn't change. Okay, it's very, very easy to see this. Gender is a new term, relatively speaking, used to be used in the area of grammar, but it actually does convey an important meaning. That it's not just the biology, the mechanics, the nuts and bolts of reproduction, but there's human behavior that is a component of that. And we define gender as the social and cultural expression of that masculinity or femininity. Okay? So now, as opposed to sex, gender, as defined as such, has varied over time and in different areas of the world, the way that it's expressed. But to show them as being separate does not mean that they're not connected. So think about it, that if we're talking about the process of procreation, how we express ourselves socially and culturally is going to have a big influence on our behavior of actually entering into a sexual union and of the rearing of children that come from that sexual union. So they're distinct, but they're actually very important. And then, because we're talking about identity, I listed here on this slide, the perception, a person's perception of whether they're being male or female. And the problem that we're going to be talking about is in the area of one's identity. And again, as we're going to see, if we have enough time to go through all of this, sexual orientation is something else we can pull out from that, but it isn't distinct from that. And it does play a role in some of what we're talking about here. Now, I don't know how many people here in the room here have seen the gender-read person, okay? Now, it's an attempt on a favorable side to be able to present those complex ideas that really shouldn't be all that complex. But the different things that we're talking about is gender, gender identity, sexual orientation, and biological sex. Now, this is one of the earlier versions. There are actually newer versions of this. The gender-read person has been offensive for some people because it looks too masculine, so there's now a gender unicorn. There's actually a gender unicorn, so they present this. The important thing here is they're presenting this to young children as early as kindergarten. And there's many ideological underpinnings of this particular figure. And I'm just going to point out one and very important figure. So they talk about this rather than sexuality as being male and female, they present it along a continuum. Now, that makes sense if you're trying to put forward the one cultural view of the human person. And they draw upon the existence and the knowledge that there are individuals that are born with genital ambiguity. You know, the first question almost every parent asks, if they didn't find out during the prenatal ultrasound, is it a boy or a girl? And it is true that there are times when the answer by the physician is, I don't know. Okay? But that's an exception to the rule, and it doesn't change the fundamental definition of sexuality. Now, where the problem comes in are the individuals that like the ones I presented, where they have a discordance of their gender identity and their sex. It's important for everyone to recognize that the vast majority, nearly all of the individuals that we're talking about with gender discordance or gender dysphoria as a part of gender discordance, have absolutely normally formed genitalia, ovaries, testes, and it's really not really an issue here. It's only brought in to be able to make the ideology we put forward. So if we remind ourselves, you know, that there really only are, you know, male and female, and in the definition of sex, there's only an ovary and a testis, right? There is no third gonad. Even in the patients that have disorders of sexual development, there is no third gonad that is able to successfully participate in that process of procreation. Okay, so we need to know that and remember that, so as we're thinking about this. Now with that backdrop here, I'm going to get into this. This is the psychiatry kind of module, and we're going to get into some of this discussion. And I want to present to you not just the current diagnostic tool, the DSM-5, that is used to define the condition that we're talking about, gender dysphoria, but step back to the previous iteration of the DSM. And in that manual, this condition was known as gender identity disorder. It was recognized as a disorder, and it was very well defined. And I underlined one feature of the criteria. So again, these are individuals that have strong and persistent cross-gender identification where their gender identity is different than their sex. And they have different criteria for what they do, you know, how we recognize that. And they exclude intersex conditions, the disorders of sexual development. When they made the transition to DSM-5, and some people in the room may be more intimately aware of this, it was a controversial topic. The change did not occur because new science became available. It was not acknowledged that this is largely due to the cultural shifts that we talked about. It was an ideological change. And in the words are very powerful, okay? So you have to be aware of how they're being manipulated to put forward this agenda, okay? So rather than talking about an incongruence between, you know, a strong desire to be the other sex, they're talking about gender, and they're trying to forget about that inconvenient fact of biology. And there are people that are making statements that sex is irrelevant and gender is sex. There are people that say that, and they try to completely abandon that. So we need to be aware of that. But there are diagnostic criteria for diagnosing gender dysphoria, and it relates to trying to normalize this condition. So the assertion is that this is no longer, it never was. They're making the statement it never was a disorder. This is a part of normal human variation. And where the problem is just the person's discomfort. And the reason they have this in the DSM at all is so that they can get the medical therapies that we're going to talk about in a minute, because they would rather have this out of the DSM altogether, because they don't want to think of this in any way related to any pathology. Okay, that's the ideology that's present, and we want to really critically evaluate that. So, you know, everybody here knows that this has become really prevalent in the discussion. And not that long ago, we almost never heard about it. We've actually known about these gender dysphoria individuals for decades, probably longer than that. They've been there quietly in the background, a very, very small number of people. We're talking a fraction of a fraction of a fraction of a percent. They're real. They exist. And you know, we've got a little bit of information about what the normal incidences are. But what we've discovered very rapidly is a marked increase, and by some estimates, 2,000-fold increase. I mean, we're going from being 0.005%, that there are some estimates, and the epidemiology is actually very poor, that will say that 0.5 to 1% of the entire US population has gender discordance. Now, it's how you broadly define it, but these are the statements that are being made. And the assertion is that these people always were there, yet they were never seeking care. And now, because the clinics are developing to treat this, that they're just coming out of the woodworks. But we can ask another hypothesis. Perhaps what we're doing by offering this treatment and the things that are going on in our culture and the discussion are driving many other individuals that had other issues that would have never presented with gender discordance. To attach that as the solution to their problems. I'm only presenting that as a hypothesis. There's no real good science to answer that question. But you know, if you like graphics, this is one center in the UK where they actually, all of the patients in that country need to go to this particular center for treatment. And this is showing you some of the drastic increases in a very, very short period of time. So that's why we're talking about it, because this is something that's become very prevalent. And there's probably over 50 centers now in the United States that are offering care. Now, before we go, again, there's a lot of background that we need to give, that I need to give you to be able to understand what we're talking about here. And the question that comes up very often is, well, what's going on? What causes this gender discordance? And the reality is, we don't know, okay? There's a lot of questions about what is actually going on. There's some evidence that there is both a genetic component to it and environmental influences. The genetic information, one of the pieces of evidence is looking at monozygotic twins, identical twins. And if you look at the concordance rate, if you have one twin that has gender dysphoria, if it was an entirely genetically inherited condition, you would expect if one sibling has it, the identical twin that was raised in the same womb and has the same genetics would also have it, right? 100% concordance. Actually, the rate is about a third, about 30% of concordance. So it does tell us that there may be some genetic influences. It does not say that there's a transgender gene. Very well, we could speculate that there's something about, we talked about resilience, right, just a minute ago, about how somebody can adapt to stress and other things. There's many other reasons why. But it's clear that there are environmental influences, and the best we can say is that most likely, like many conditions that we deal with, that this condition is multifactorial. That there are many different factors, both environmental and perhaps genetic, and many different genetic influences. And that in any one individual, the contributing factors may differ, both in nature and in magnitude. And this is going to be very important as we address the scientific studies that are going on or not going on. All right, so let's get to the meat of the matter here. We're talking about interventions directed as medical personnel coming to our realm to be able to have their body manipulated in a way to conform with their gender identity. Now, the traditional approach for this, again, based as reflected in the DSM-4, was that this was an objective mental disorder And therefore, the focus was on addressing psychological factors that might be addressable in the area of psychiatry and psychology, and also to take an expectant approach to accompany that individual, to try to help them with their anxiety, with their depression, and the other things that they're experiencing, but largely to wait. Okay? Why was that? Well, the data showed that in children, the vast majority that present with gender discordance, if merely left alone, will have resolution of their gender dysphoria. They will realign their gender identity with their biological sex by the time they complete puberty. The estimates range from about 50 to about 98%. I think the best estimates are about 85%. The advocates that are pushing forward for this agenda challenge this data, but there's been nearly a dozen studies over 40 years, some with methodological flaws, none of them perfect, but they all consistently show the same answer. Okay, it's undeniable that this is an entity that in children, most of the children that present this way will have realignment, at least historically speaking. Now, once they get through puberty, the later they go, or if they develop this later in life, the numbers are lower than that. But now we're going to shift to the current paradigm, which actually, as reflected in the ideology, because gender dysphoria, okay, is a normal variation of biology, is what it's being asserted, that the goal is to be able to alleviate that, but we don't need to challenge that there's a discrepancy between the identity and the biology. So the focus is on treating the dysphoria, trying to be able to alleviate the difficulty that these individuals have. And because, as I said, from the ideology standpoint, the mind is correct and the body is diseased, they look at a normally formed body as now being the diseased portion and say that the brain is perfectly healthy. They actually seek this medical intervention, okay? And what does that look like? I'm going to spend a few minutes going through each of the different components, but one of the first interventions is something called social affirmation, so that they actually actively encourage them in transitioning the way they present themselves to other individuals, both at home and in their social environments. When they start going through puberty, again, this normal process that happens in everyone as they go from being a child to being an adult is also considered a disease. Okay, and so they try, if the dysphoria is exacerbated with puberty, the goal is to suppress that from actually happening. And then if they persist in their gender discordance and their gender dysphoria, then they're being offered cross-sex hormones by the time they're 16 years of age. And then by the time they're 18, they'll be offered surgical intervention to change their bodily appearance. Now, I will say those are the numbers from not that long ago, and the ages keep going down earlier and earlier. The argument is, why wait that long? Why don't we do cross-sex hormones at 10 or 12 years of age? Okay. The social affirmation is being advocated very early on, as early as 3 years of age. And I'll talk a little bit about that as we go through the specifics of that. One of the challenges that we have in even raising the questions is that what I just described to you now is codified in the recommendations and the clinical practice guidelines of many professional organizations. And Ellen this morning really mentioned very well, kind of how that process goes on. It's not all of us in the room here being privy to that consideration and participating in that discussion. A very small fraction of the societies are actually involved in making these guidelines. But what we should do is look a little bit about what we mean by clinical practice guidelines. Okay, we use them all the time in medicine. There are actually benefits to them, especially when there's a large body of data and there's different approaches to treatment, trying to be able to synthesize the data and make it accessible to the practitioner and to the patient. And again, very beneficial. But they're only as good as the evidence that's present in the guidelines. And there are dangers in clinical guidelines if they shut down dialogue and if they prevent us from getting the answers that we really don't have. Now, I'm a pediatric endocrinologist, so my field of expertise in endocrinology, I'm most familiar with the Endocrine Society guidelines. And fortunately, like most clinical guidelines, if they're done properly, or at least the way that we would expect, we want to know what the evidence is behind the guidelines. Not everybody knows that when we look at the Endocrine Society guidelines, within the guidelines themselves, nearly every single recommendation that's contained within them shows that there's the lowest quality of evidence present for the recommendations that are being made. So low quality evidence, strong recommendations. By definition, the low quality evidence means that as more evidence becomes available, it's very likely that the recommendations will change. There are a few areas where it gets up to the moderate level of evidence, and those are for complications, okay, not benefits for this treatment. Very important to know this. So as a physician scientist, and we also know that there are many other examples of clinical guidelines that have been put forward that only later we find out are completely wrong, right? We know of many other situations like that. Normally, now this isn't unique to gender dysphoria, okay? There are other guidelines that are present that have low quality evidence as well. We try to do the best we can. Usually we look through a risk-benefit analysis, and when we don't have full answers or poor quality data, if we're going to do anything at all, we proceed very, very cautiously. Not happening in this particular area. We're going full throttle, and in fact, shutting down anybody that challenges the information. And I'll go through some of the studies that have been done and that are being done right now and question what's going on. So let's get for a minute to the actual data that we have in hand here. Now, it's sad to say that when we talk about low quality evidence, it's readily acknowledged. What are the problems and why is it low quality evidence? Well, first off, there's very few studies that have been done. They're often done with very, very small sample sizes, sometimes as few as a dozen or 2 dozen patients. I said earlier, it's likely a multifactorial condition, right? So how many people would readily adopt a new heart therapy or diabetes therapy based on a study done in 12 patients? Anybody? Well, this is what's going on. So small sample sizes, many times convenient samples. So they recruit their patients by putting an internet survey out there, and there's an inherent bias in doing that. The studies themselves have an uncontrolled design, so they either have improper controls or no controls at all. They're largely retrospective. So when we talk about the randomized prospective controlled trial, generally they do not exist in this area of research, okay? I'm not talking blinding, I'm talking just doing the studies, and it's actually asserted that it's unethical to do those studies. And I would say it's unethical not to do those studies. What people are often saying is that they've mistaken that a control group has to be no intervention at all, right? I don't think any of us would say we're going to leave these kids alone and just see what happens on their own. But we can propose hypotheses that can actually be done in a controlled manner, very carefully, with all the safeguards that we normally do for experimentation in children, and be able to at least move the field forward. And as you'll see when we get to the outcomes data, there are even more concerns. I'm not even started yet as far as what's going on here. So let me step back. I mentioned the first intervention that's proposed is social affirmation, and again that involves a number of things, name changes like our patient that I presented, pronoun usage. This is a major topic. You're all going to be confronted in your hospitals as far as making sure that you don't offend somebody by using improper pronouns. It's something that is becoming more and more of an issue. Cross-dressing, in schools, in children, bathroom use, what sports team they can be on. And again, this is advocated as early as 3 years of age. Now, the Endocrine Society guidelines first came out in 2009. They were just updated last fall. In the first version that came out in 2009, social affirmation was recommended against because of the desistance data that I mentioned. Okay, there was a concern that if we did the social affirmation, we might be altering the trajectory of these children and pushing them in a direction that they otherwise would not take. With the advancing ideology, that statement was clearly modified and moderated in the updated version of that. And I will tell you that in the area of evidence, for social affirmation, again, low quality studies, they do show that when you socially affirm a child, that they do feel better. Okay, we acknowledge that they feel better because you're acquiescing to their what they want to occur. You know, if you take a toddler that's screaming for a candy bar and you give it to them, they're going to be satisfied with that, right? Okay, there are differences, but I'm just pointing that out. So there are short-term studies that show there's a reduction of dysphoria, and we have to question what the control groups are. But they're really, the long-term studies show that and again, we're going to get into some of the long-term studies, that they really, it does not completely solve the problem. And there really are no randomized controlled studies about bathroom use and pronoun use at school. It's just assumed as fact that this is the way we have to go. And when you talk to somebody that's engaged in advocating for this, they will acknowledge the limitations of the study, but it doesn't change at all the vigor with which they assert that you absolutely have to do this. So in many respects, from social affirmation standpoint, this is experimentation. Okay, but it's uncontrolled and unconsented, and beyond that, it's forcing other people to participate in that research project. Okay, the school teachers, the parents, and anyone that is involved with these children. Now, moving on to the second step of therapy, that's the pubertal suppression. And again, just pointing out the obvious, the pediatricians in the room will certainly be intimately familiar with this, but I would say all of us are familiar with this, that when we go through our transition from childhood to adulthood, puberty, and I'm talking about the physiologic changes that occur, is only one component of that process. We all know that there's something else that goes on at that time. It's called adolescence, right? All right, it's not just the bodily changes, and it's a very traumatic time for anyone. Okay, there's a lot of searching for identity. Look at junior high as far as the way children treat each other. They're trying to try on different hats, and they're trying to figure out who they are. So when we talk about pubertal suppression, we have to keep this in mind. Now, the rationale for doing pubertal suppression, and just for those of you that aren't familiar with this, these are powerful drugs that are given to shut down the hypothalamic pituitary gonadal sequence of development. We traditionally have used these to treat children that have gone in through puberty abnormally early, and it's also used in adults to suppress that axis during cancer treatment, for example. The claim is made that this is entirely safe, fully reversible, and the reason we want to do this is it alleviates the discomfort, and that's true, and it gives the child more time to explore whether they really truly are transgendered, and it's going to improve the cosmetic effect if we want to continue this therapy long term, because we're going to prevent those bodily changes that are going on. So that's the claim that is made. Let's look at the evidence. Okay, first off, let's talk logic. Okay, we're talking about the interruption of a normal developmental process. Okay, I hope there's some developmental biologists in the room. So think about this. Okay, it's true that if we give pubertal blockade for 3, 4, 5 years, okay, and we stop that the signals from the brain will start working again. In that respect, it is reversible. However, okay, we can't turn back the clock. We've interrupted a normal developmental process, all the things that would normally happen for adolescents, and when we resume that pubertal change 4, 5, 6 years later, okay, it's not the same thing as what would have happened when the child was 8, 9, 10 years of age, okay? The claim that it's safe, it's not been studied. It's been studied for other conditions. It's not FDA approved. It's an off-label use of the medication. We do use medications off-label, but we don't make the claim that we have the answer that is fully safe before we do the studies. Okay, very important. There are studies that give, puberty is a time where children develop their maximal bone density that's going to be important for the rest of their life. Okay, we know this from other conditions, and when you don't get that bone density, you're at a much higher risk of osteoporosis when you're older. And we can actually see those changes going on. Again, we can't turn back the clock and get that. One of the most concerning things is that we're talking that when you give pubertal blockade, particularly when you follow that up with cross-sex hormones that I'm going to speak about, you induce a state of sterility. You don't allow the gonad to develop, okay? And you're doing this, remember, you're doing this in a child that really hasn't fully developed and has really no full concept of their sexuality and this whole process of reproduction. So you're making them infertile, sterile at this point in time. And it's actually acknowledged by the people that are offering this care. They will actually tell their patients, you can expect that you're not going to be able to have your own children. Or there are other attempts, okay, to figure out, let's find a way that we can restore fertility in individuals that we've intentionally destroyed it. Okay, they were creating infertility and then we're trying to make a business of trying to reverse that. Then the other component about what it's going to actually do in the progression of this disease, okay, and there is some pretty concerning data. I said earlier, you know, about 85% of these kids are going to realign their gender identity with their sex if you leave them alone. In the few studies that have been done giving pubertal blockade, nearly all of the patients go on to have cross-sex hormones. So rather than having a 15% persistence, we go to 98%. Okay, so the evidence is not great. It wasn't designed for that purpose, but it gives you at least some caution there. Now let's talk a little bit about cross-sex hormones. Okay, I'm not going to say a lot about this. You know, keep in mind that estrogen and testosterone are present in both males and females. The levels are very different in males and females. They vary throughout life. But when we get back to what we know about human sexuality, right? The sexual differentiation that occurs in the formation of the gonads, the differences between male and female are not restricted to the gonads, right? What is the most sexed organ in the body? It's actually the brain. Every cell in the body has genetic differences. Okay, epigenetics, modifications of the DNA that affect the expression of various genes, and we know this from a scientific level very well. Our National Institute of Health requires us, when we're doing scientific studies, to study both male and female subjects. Unless we can justify the reason we're not doing that, because the results will be very different, the response to various therapies. So giving testosterone to a male is very different than giving the same hormone to a biological female. Okay, and the same can be said about estrogen as well. We don't have full answers. These have been studied for long periods of time. There's been an evolution in an attempt to actually generate this data. I already mentioned the sterility. There's other things that we already know occur. So stroke, again, when you're getting estrogen, polycythemia, cardiovascular disease, metabolic changes. The cancer is really, there are two components to that. I think it's a little bit weaker in the case to be made for that. And it depends on, but again, some of these studies haven't been done long enough, you know, to be able to know whether anything's going on. In the short run, there may not be direct effects related to normal tumors that develop because of the hormones. But we already know from other areas that the risk of cancer differs between males and females for many types of cancers. And the other thing is a problem with individuals that are presenting as the opposite sex, not even getting in to get the screening for the cancers that they might develop. Okay, going to your provider, not telling them, they're trying to conceal their true biology, and they're missing out on the opportunity to do that. So there's a lot of questions about cross-sex hormones. I've actually written a paper about this, looking at an ethical analysis of cross-sex hormones, and go into much more detail about that. But I'm just going to leave it at that for right now. Let's, in the time I have here, talk about some of the benefits and risks and benefits, both short-term and long-term, okay? So in the short run, I already mentioned that there is an alleviation of dysphoria. I think the studies aren't perfect, but they do show evidence of that. And I gave at least one potential explanation for that. An improvement in depression. There's a slight persistence of increased anxiety. Most patients, when they are presented with this therapy, in the short run, will be satisfied. Actually, they're very relieved, and they're very grateful to the provider for being able to do this. Now, before I get into the long-term effects, I just want to draw attention to what is actually going on here. And I saw there was a poster on body integrity identity disorder. You know, these are patients that are completely normal physically, but they have a perception that they should be an amputee, and they seek out medical intervention to amputate their limbs. I don't know if people have heard about this. It's a real entity, okay? And surprisingly, there are now some surgeons that are willing to go forward and acquiesce to that, believe it or not, okay? But at least that we don't have the same degree as what we're talking about in this condition. Probably the one that you're more familiar with is anorexia nervosa, right? So how many in the room, again, ask the question, that somebody presents, it's the same, very similar, they're different, but there are similarities, okay? That the reality of their body is different than what they perceive. They think that they're obese, but they're really undernourished. How many people would address that by doing gastric bypass surgery or liposuction to alleviate that discomfort that they have? It just doesn't make any sense. Now, when you present this to people who are doing this, they object very strongly to this. I think one of the ways that you get away with this is because some of the things we're talking about in gender dysphoria are not as immediately apparent, okay? If you did that in an anorexic individual, you would see immediate problems. Now, let's talk a little bit about long-term outcomes, and I again want to come back to real people. I've been talking a lot about facts and figures and scientific studies. The literature on long-term effects is also very poor, but the data we have is concerning. Walt Heyer is an individual. He has a very, very interesting but actually sad story of how he identified as being transgender, went through medical, both hormone and surgical therapy, only to find 8-10 years later that he wasn't fixed, and actually sought to reverse that reversal attempt that he had. He's on the internet. You can Google him. He has a growing number of people contacting him that have had similar stories. Okay, these are anecdotes, but they're very real people that are involved here. And there's emerging evidence. It's not everybody, but you can't probably read this slide completely. But what it points out here is this is just a short survey, and in fact, that these individuals are a small percentage that are reported in the literature. Some of the long-term follow-up studies have a notorious problem with dropout, meaning that if you try to look at them long-term, a large percent of them are lost to follow-up. And you might think a number of different things, but one of the things might be that they're not happy with their outcome and they never went back to their provider. At least we could speculate that. The other important thing about this is if you look at the amount of time between the time that they have regret, generally we're looking at about 8, 10, 12 years. And the studies that are going on right now have not been carried out that long. But there are studies looking at, again, they're not perfect, that are concerning. This is some data from a couple of studies. There's a Swedish cohort where they're looking at long-term morbidity. This is a Kaplan-Meier curve showing death rates over time, whether you're in the background population or you were transgendered and underwent treatment. Now, this was not designed in a way that we can actually evaluate what the effect of treatment was per se, but we see that the patients that underwent this treatment have a markedly increased rate of death over time. You'll also see in this curve here that they parallel very closely to about 10 years, and they start to drop off. So what we can say with confidence, okay, even though we can't say whether the treatment influenced that, it did not fix the problem, right? Now, what the advocates will say that this is all related to social stress, and we just haven't accepted them fully, and that if we took care of that now it's not to dismiss that people can have stress when due to social factors, but I think it's overstating it and raising some suspicion and some concern about this. And this is not just one study, okay? There's a meta-analysis that was done last year, over 40 studies looking at the suicide risk in patients that have undergone treatment, these are in adults, showing that the suicide rate did not improve. And in fact, a very small number of studies here looked at before and after, the rate of suicide ideation or attempt actually went up. Okay, so there's some emerging evidence right now that long-term this is not a good idea. So even if you're not concerned about all of the philosophical and theological and moral issues associated with this, on a scientific basis alone, there is grounds to question what's going on. Okay, and I want to empower all of you to be aware of this data to be able to engage in that conversation. In the last few minutes, and I want to make sure that I make myself available for questions, is I just want to touch on some of the ethical concerns here. Some of them were present throughout the talk, so I'll go pretty quickly here. So really what we're doing is we're experimenting on children. We don't have the data that this is safe. We're not getting consent. In all areas of research, when we're embarking on treatments that we don't know what the outcome is, we call it experimentation. We have institutional review boards that will actually look at the safety of this. The bar is even higher in children. Okay, we have very, very high standards of not putting children at risk. We're not telling the parents that we're experimenting on their children, we're not getting their consent. I think it's a major area of ethical concern. Beneficence, I already told you that there's some questions about whether it's truly beneficial for these individuals. As far as issues of autonomy, we're talking about children here. These are children that we don't let them vote, we don't let them buy cigarettes or alcohol. There are many things we don't let them drive until they reach a certain age. We're letting them make a lifelong decision about their future. And many areas, the way that it's moving forward is that if the parents object, they're considered that they're abusing their children, and there's efforts to remove them from the home. That's actually happening in other areas of the world, but also in our country here as well. I'm just telling you this is what's going on. Okay, so autonomy, and then the last is non-maleficence, and I've seen this twisted by the people who are advocating this therapy. Basically, that there are many areas of medicine where we don't have effective therapies. The first principle is that when we don't know what we're doing, at least let's not harm our patient, right? And people are making the argument of non-maleficence. They're saying that if you don't treat, you're harming the individual. I think it's twisting the logic of what's going on. We need to be very vocal about this, at least in raising these concerns. So lastly, what can we do? There's so much that we need to know. I think many of the people in the room here, I think you can be a part of the solution here. You can at least be able to dialogue with your colleagues, and you can do this with confidence, based upon scientific evidence. You don't even have to talk about your faith, and be able to work toward a truly helpful solution. So I think there's some things that we can agree on. First, we should all have compassion for the suffering that these patients experience. We should not be driving them away from treating them. There is, just by getting them, patients that have gender dysphoria will avoid getting medical care, period. They avoid going to the doctor, okay? Just by getting them in the door, giving them immunizations, providing normal health care, you can make a tremendous benefit in their overall health and well-being. We can work with them side by side, okay, in eliminating unfair prejudice and discrimination and bullying. We would all agree that that's wrong, that we shouldn't be tolerating that in any way. But that doesn't necessitate us acquiescing to a false understanding of who that individual is. We don't have to jettison biology and science to enter into that. We can provide a quality evidence-based psychological support, okay? We can walk with these patients, we can enter into and we can work with their depression, work with their anxiety, just like we do in other areas where we can't fully resolve the issue. I don't know, with the evidence that's available, some of these individuals where we'll ever be able to help them to align their gender identity with their sex. Many of them from historically may not actually be able to do that. But there are things that we can do to actually help them in this process. And part of it is affirming their human dignity, walking with them, and then helping them to lead them to truth, okay? And with that, I'm going to conclude. I want to thank you so much for your attention. I'm happy to stay as long as you'd like to answer any questions. Again, thank you very much. So my understanding is that slides will be available. Come talk to me after the talk. There's some issues of the way that this information is being used. I think this information does need to get out there, and I'd like to empower all of you to be able to speak well about this issue and intelligently with the data that's there. All of the data there is verified. I can give you a whole list of references to look at.